राहुल। बहुत अच्छा है ना। Good evening, Pankaj sir. Rahul,
Yes, sir.
who is presenting today?
Sir, total three students are presenting today.
Haji.
Yes, sir. First is Sir Dr. Velan Mukani, then Dr. Shashank, and Dr. Karan, sir.
They have joined?
We can see them, sir.
Okay, let's just wait for 5 minutes. Dr. Mahendra Pal sir will join or Ganesh Bakshi sir. And then we
Yes,
can
sir.
start.
Okay, sir.
Gaurang Shah sir is traveling, so he may be on and off.
Yes,
So
sir.
I will just call Mahendra Pal.
Okay.
Dr. Saurabh Patil was going to join us, right?
Yes, sir. Saurabh sir has joined, sir.
He has joined?
Yes, sir.
Yes, sir. I'm here waiting
Hi,
for
hi,
people
hi.
to
Hi,
join.
Saurabh.
Hi.
Good evening.
Good evening.
Gaurang Shah sir is traveling, so
Yeah, he had called me.
yeah,
No
so he
problem.
said we can start the meeting, and sir will join on and off
No
as a
problem.
possible. So Saurav sir is already here. I think Pankaj sir is also joined. So I think you can start, Rahul.
Yes.
Dr. Saurabh is here. He will take the lead. Rahul, you can start the presentation.
Sir, we have a lecture. We have a presentation from Dr. Saurabh sir first.
Okay, okay,
Then
okay.
we'll go for case discussion, sir.
Perfect, perfect. Saurabh bhai, when you are ready, we can start.
Yeah, I'm ready. I'm just sharing my presentation.
Ji, ji, ji.
Is this visible, Rahul?
Yes, sir.
Yeah, good. So, good evening, respected faculty, my seniors and dear colleagues. At the outset, I would like to thank Dr. Gaurang Shah sir for giving me this opportunity to discuss on the management of non-muscle invasive bladder cancers. So, in last few years, we have seen a significant shift in the management pattern, the paradigms of non-muscle invasive bladder cancers, mainly focusing upon the betterment of risk stratification and moving towards novel intravesical therapies and the bladder sparing approach. My discussion, I will focus mainly on exam point of view because most of the attendees are trainee and urology residents, focusing on what we know as per guidelines and what is there in the horizon, important trials in brief. So to begin with, whenever we see a patient of bladder carcinoma, usually they present with a painless gross hematuria. The first thing that we do, or they already have gotten done, is bladder ultrasonography or ultrasonography of kidney ureter bladder. And then what is the role of biomarkers? Biomarkers which we are usually routinely using is a urine cytology, which has a very good specificity but very poor sensitivity. There are newer, or maybe we are using this quite a few years, RNA-based, methylation-based, and DNA-based biomarkers. But what is the practical use of these biomarkers, or what is the importance as a trainee or exam point of view? Currently, the guidelines do not recommend their use, and as per AUS statement, they should not be used in place of cystoscopy or TRBT for the surveillance or even the diagnosis. So, urine cytology can be used in surveillance, but for primary diagnosis, no urinary biomarkers can replace cystoscopy or TRBT. So, main thing for diagnosis remains the CT urography. The role of MRI in the form of VIRAT score. Again, VIRAT has a very good sensitivity and specificity in distinguishing non-muscle invasive and muscle invasive, mainly for muscle invasive and to some extent T3 disease. But can we use this Virad score to replace TURBT? There was a study, bladder path trial. You can remember this name, bladder path trial, in which this is a UK-based study in which published in JCO, Standard Good Journal, in which they compared the standard approach of doing TURBT followed by routine treatment versus doing MRI first and then distinguishing them on Virad score, Virads 1, 2, 3, 4, 5 between non-muscle invasive and muscle invasive, and then doing TURBT only for non-muscle invasive, for muscle invasive diagnosed on MP-MRI.
Saurabh, I'll
They did
stop
not,
you for a second. Your
yeah,
slides are not moving and it is not full screen.
I already, I think from my side is full screen, sir.
No, no, we can only see the first title slide where management of NMIBC is written.
Oh, okay. But
Yeah, just stop sharing and share again. I think there
okay,
is.
okay, sure,
Yeah.
sure, sure, sure. Can you see full screen now, sir?
It is still not full screen.
Oh, okay. So Rahul, can I share my slides to you? Then you can start from your side. Rahul?
Rahul,
Yes, sir. Please, you have my mail ID, sir. You can send me there. I'll
Okay.
do this right now, sir.
Okay. So give me 5 minutes. Okay, I have sent it to you, Rahul. Just check once and if possible, try from your side.
Yes, sir. Give me 1 minute, sir, please.
by the time he is loading the presentation, recently we were discussing bladder cancer, and I think Saurabh, you gave very good light on this topic that whether the markers can replace cystoscopy. So I think that is a very good point for the exam going students. So we were discussing regarding the markers and whether virides and the markers can really replace TURBT. So it's a
So
very good
currently,
point.
yeah, currently, as per guidelines, no marker can replace cystoscopy as per
Absolutely.
diagnosis is
So that was
concerned.
a very good point,
Yeah,
very good
yeah,
take-home
correct.
message
For
for the
surveillance,
students.
maybe we can use,
Yes, yes,
yes, correct.
yes,
And
perfect.
VIRATs also, the same thing. We cannot use VIRATs. We cannot bypass TURBT.
Yes,
TURBT is not only for diagnosis. TURBT is also for giving a good therapeutic benefit even after, for example, after chemotherapies, after trimodal therapies, bladder saving therapies.
yes,
TURBT is
yes.
very important. Most important thing again is the variant histologies can be diagnosed, which cannot be diagnosed on these VIRATs
Absolutely,
following.
absolutely. Histopathology cannot be replaced. another scenario that Gaurang Shah sir was discussing with our PG when he was presenting is, he said that there is a large mass in the bladder, and sometimes it's an obviously spread tumor, or it is already going out of the bladder. In such a scenario, sir said we can just take the biopsy. But then I gave another scenario. I said that what if you see like 2 or 3 resectable tumors? You would still want to resect them because you don't know what happens to the patient, right? Sometimes they may become unfit for the next surgery or for the radical cystectomy, or you may want to do a bladder preservation protocol, or patient may go away to somebody else. So at least when the patient has come to you with hematuria, you should at least do your resection and complete it wherever possible.
Yes, correct.
Because that case that we were discussing, patient had very alarming hematuria. So in that case, we discussed these two scenarios, that there is a resectable tumor and there is a tumor which is filled the bladder completely. Rahul, are you ready?
So is it visible to everyone?
Just 1 minute. Huh? Yeah. So whenever sir says, you just change the slide, okay?
Yes, sir.
correct.
Yeah.
Okay, so next slide. So we will be discussing mainly based up. Next slide, Rahul.
1 second, sir. 1 second, sir.
I think it's going to be very cumbersome because I have too many slides and there are too many pointers also. Yeah. So as far as diagnosis is concerned, go back to first slide. Patient usually comes with a painless gross hematuria. We do, or they already have urine ultrasonography, and then next thing what we do routinely in practice is CT urography. The role of biomarkers or cytology is usually limited. They cannot replace the cystoscopy. Next slide, Rahul. They cannot replace the cystoscopy. Next slide, please. So as far as guidelines are concerned, yeah, next.
Rahul, next.
No, Rahul, what we can do is I will share from my side. I will not do full screen. I think if it is visible without full screen, because this is not going to, it is difficult for me also to present. You stop sharing. I will try again.
Yes, sir.
Okay. Is it visible now?
Saurabh, it is visible, but not as full screen.
No, full screen is okay, sir. I mean, if you are okay, because full screen, if I do full screen, it is full screen from my side. So which slide are you currently?
We are seeing diagnosis.
We are
Diagnosis,
seeing
correct?
your fourth slide,
Right.
AU statement.
AUA statement, urinary biomarker should not be used, right?
Yes.
Okay. So I think this is full screen from my side.
Sir, actually, what you can do, sir, you can first start present as a presentation in the background and then share the presentation. So then it will start running, I think.
Sorry, come again. What?
Sir, you can start it in the presentation itself. First, you go, you just minimize the Zoom screen, start as a presentation in the PowerPoint, and then share that screen. Then it will start running like it's down, sir, down here.
Where? Here, no?
Yes, sir, yes, sir, yes, sir.
This I have already done.
No, Saurav, he's saying first you stop sharing.
Okay.
Go to your presentation.
So I've stopped sharing.
Yeah, go to your presentation and do full screen.
So on your Saurabh, on your desktop, you minimize the zoom.
Yes.
Open the presentation, make it full screen.
Correct.
And now open the zoom again and now share the screen.
So once I do full screen, I cannot. I mean, with this, I cannot open Zoom link. I have to again do it.
If you touch your cursor, you will be able to see the Zoom link.
No, sir. I have to exit.
Saurabh, time has come to buy a new laptop.
Sorry? No,
Time has
laptop.
come to buy a new laptop, Saurabh.
No, laptop is good, but I think I am old, technology-wise. So, let me try last time. Is it okay, sir?
Sir, otherwise you save your file to desktop, sir, and then again open.
I have already.
Desktop, separate file, sir.
Okay. Now, same thing.
Yes, same thing.
Is it moving now?
No, it is not.
Not
No,
moving.
slides are not moving. Slides are not moving.
So,
So I think Saurabh, आप यहीं से ही आप slide move करते जाइए and enlarge it as much as you can.
आणि पॉवर पॉइंट वर टाकून दे म्हणजे ते प्युअर पूर्ण स्लाइड दिसेल ती.
सर पॉवर पॉइंट वरच आहे पण तिकडे होत नाही माझ्याकडून पॉवर पॉइंट वरच येत आहे. I don't
But
know.
at least your slides are changing now. Saurabh, just try to change. Let us see. Diagnosis आया.
Sir, there is that 58% marker at the corner, sir. You can just drag it so that it will be zoomed in, somewhat zoomed in, sir. To say 70%.
I'm not getting what?
Sir, there is a marker in the right-hand corner, sir. That is at 58%, sir. You can
Correct.
make it till 75.
Okay,
so
okay,
that it fits in the screen. Or
Okay,
yes,
okay. This is better?
Yes.
Yeah. But slides are moving. They are not moving, I think.
Can you see now?
Now
Slides are
yes. Okay,
moving?
go ahead. Yes, perfect.
Okay. So what I
Moving
was
now.
discussing is as per AUS statement, neither cytology or virides can replace a standard TURBT. So there was a study published in JCO by UK people in which they try to do only MPMRI and get away without doing TURBT. In their cases, the intention was to fasten up the treatment, but the thing is, again, in our scenario, in Indian practice, obviously there is the answer to current status of MPMRI, though it is good in diagnosis or differentiating between non-muscle and muscle invasive. We cannot just go ahead without biopsy. We have to do TURBT, standard TURBT and biopsy. So again, TURBT is the most important step in diagnosis of bladder cancers. Monopolar, bipolar, en bloc, routinely asked in exam, whichever way you use. So there are multiple RCTs published for en bloc versus conventional monopolar or bipolar. So for multiple tumors, like up to 3 tumors, ranging between 1 to 3 centimeter sizes, there is a significant reduction in 1 year recurrence rate when used en bloc laser TURBT versus conventional monopolar or bipolar. There is a higher rate of detrusor in the pathological specimen and lesser rate of obturator reflex. But again, as far as oncological benefit is concerned, long-term oncological benefit are equal in whether you use laser en bloc or you use monopolar bipolar. So for exam, whichever way you are comfortable, whichever way you have done it, you have to answer. Again, TURBT more than whether it is en bloc or laser or monopolar bipolar. Most important thing is a complete TURBT. And again, like we discussed, is not only for staging, but also to give a complete or better outcomes after intravesical therapy. bladder sparing trimodal therapies, and it gives a good PT0 or YPT0 after chemotherapy, good clearance of the tumor. So as per again AUA guidelines, when repeat resection is required, so whenever we see high grade in the first muscle, first pathology, and T1, we should do repeat resection or re-TURBT within 2 to 6 weeks. Again, the same thing recommended by all the guidelines. Whenever we see T1 or high-grade lesions in the specimen, we have to perform restage TURBT after 2 to 6 weeks. So this is the overall management. I'll discuss step by step. Most important thing in NMIBC management is the risk stratification. So risk stratification, as per the multiple guidelines, we know the low grade classification being the solitary less than 3 centimeter, low grade PTA mass or pendulum masses, and high grade being the any T1, any high grade carcinoma in situ, multiple recurrent high grade TAs, and patients with variant histology. Now, if you compare, there is a small confusion in the intermediate risk category between EAU definition and AUA definition. If you see here, the high-grade TAs are included in AUA definition, but whenever it is less than 3 centimeter. But as far as EAU definition or classification is concerned, high-grade TA are always considered in high-risk definition. We have discussed this with Dr. Ashish Kamath also in one of the conferences. He also said most of the times the high grade is considered to be a high risk. So in exam, you should ideally say whenever it is high grade, even if it TN less than 3 centimeter, consider it as a high risk disease. Again, second point in AUA intermediate risk classification is low grade T1. Most of the pathologists, oncopathologists, they say that this particular entity does not exist. Whenever it is T1, it has to be high grade. So usually, very rarely, low grade T1 rarely exists in the practice. So what is important is we have to sub-classify this intermediate risk, though it looks very simple or innocent. So IBCG International Bladder Cancer Group has differentiated this particular intermediate risk into 3 classifications depending upon the risk factors, whether they are prone for recurrences and progression. So depending upon how many factors are present in the intermediate risk group, for example, that the number of tumors, the recurrences, the time of recurrences, the tumor sizes, and previous intravesical treatment. Depending upon that, they have sub-classified this intermediate risk group into 3 categories. One with 0 risk factor, 1 to 2 risk factor, and more than 3 risk factors. So whenever there is 0 risk factor, it behaves as a low risk type. But with 1 to 2 risk factors, it behaves like an intermediate, and whenever it is more than 3 risk factors, behaves like high risk NMIBC. Why it is important? Because the probability of recurrence and probability of progression, if you see here for 0 risk factors, the probability of recurrence after 5 years is in the tune of 38.5% versus the more than 3 risk factors is 78%. And the progression is less than 5% for 0 risk factors. And whenever the risk factors are more than 3, it is 17% progression to T1 from the TA group. Focusing upon the management of non-muscle invasive bladder cancers. So low risk, there is no confusion, TURBT followed by a single dose post-surgery mitomycin C for 40 milligram. Surveillance cystoscopy first at 3 months, if it is negative at 12 months, and then subsequently once a year for 5 years. As per guidelines, there is no role for frequent urine cytologies or frequent CT scans. So there is usually no confusion for low risk tumors. For intermediate risk, again, AUA guideline recommend intravesical chemotherapy first. If the recurrence is after chemotherapy, then intravesical immunotherapy. So usually 6 weeks induction course followed by once a month maintenance course for a year. Again, by IBCG recommendation, we have to risk stratify this intermediate risk group into 3 categories. If there is no risk factors, then you manage with like a low risk NMIBC, in which we can do cystoscopies, office fulguration, sometimes chemoablation, or just an active surveillance. Whenever there are 1 or 2 risk factors, intravesical chemotherapy, and more than 3 risk factors, intravesical chemotherapy for intermediate risk bladder cancers. This is a particular subtype usually rarely seen, but difficult to treat, or maybe there are multiple newer options coming up. The low risk with zero risk factors. To avoid the multiple uses of TURBT and the toxicity and cost associated with TURBT, their options are office fulguration of the small recurrent masses, observation, not doing anything, and chemoablation. Now, this chemoablation is something which is now, it is not very new therapy. It is practicing for more than a decade, but now there are newer advances. For example, this JCO trial published in 2022, Dablaka study in which the intensive MMC was tried 3 per week for 2 weeks, followed by SOS TURBT versus TURBT with induction for these recurrent low-grade masses. Plus, they also included some high-grade masses. And what they found was this was much tolerable, and they found that very few patients required procedure during the 2 years of follow-up. So even if we don't do TURBTs, even if we do only mitomycin C chemoablation, we can manage these low-risk recurrent group tumors. This is something new molecule which is recently been FDA approved. So UGN 102 is a formulation of mitomycin C, which is in a form of reverse thermogel. It is in the 75 milligram dose. It is usually in normal temperature, is in a liquid form. Whenever we instill it in the bladder, it turns into the gel form and it sticks to the bladder. And even if it stays there for at least 6 to 8 hours, so it gives a prolonged exposure to the bladder tumor with mitomycin. So even if any patient passes urine, it is not excreted immediately. And so this was studied in two multiphasic randomized controlled trial. One is Atlas trial, which is already been done. So low-grade intermediate risk patient, they studied this UGN molecule versus TURBT. The only problem with this study is they did only TURBT, which is not a standard practice. We obviously give some form of intravesical therapy after TURBT. And what they found was there was a good response at 3 months. And this 3 months response was durable at the end of 1 year. So they had 80% durability of this response with this newer molecule compared to only TURBT. And again, the side effect profile was more with this UGN molecule. But the thing is, the side effects were more tolerable. And the reason for discontinuation because of this treatment was in less than 4% of patients. Similar study, not a randomized control trial, but an ongoing prospective phase 3 trial, in which again 6 weeks of intravesical installation of this newer molecule is given at the dose of 75 milligram intravesically. Again, they found a similar result and with good durability of response. Only problem was there was slightly higher incidences of adverse events. But again, like we discussed, the discontinuation because of adverse side effect was lesser than 3%. So they concluded that this is a well-tolerated and clinically meaningful treatment as far as this low-grade, low-risk cancers are confirmed. The only issue with this molecule is it is very costly, not yet available in India. It is very costly. And it is for such patients which we can usually manage with just office fulguration or observation. So chemoablation for this particular setting, as far as this newer molecule is concerned, has still a question mark as far as our guidelines are concerned. Follow for intermediate risk patients, cystoscopy at 3 months. If it is negative, then we have to perform 6 monthly cystoscopy for initial 2 years. Again, if all cystoscopies are negative, then yearly ones for 10 years. High risk, we already know the risk stratification. Again, there are some differences between the AUA, EAU, and NCCN. What I like about NCCN is they have compared the high risk with very high risk, and this particular subgroup in which there are BCG unresponsive or refractory cases, variant histologies, lymphovascular invasion, and prostatic urethral invasion. These are usually candidates for to consider for early cystectomies, because they are associated with poorer intravesical results. So management usually starts with BCG. We already know that the dose induction was plus maintenance. I will not go in detail with the management of routine BCGs. I will go directly to BCG failure when what newer therapies are there. So why BCG failure is important? Because it is associated with almost 40% risk of progression to muscle invasive disease. So these are the people which we have to detect early in their life, because if we miss this window, they are going to go into the muscle invasive and ultimately to the metastatic disease if we don't treat them early. So there is a risk of waiting for radical cystectomy. So there is a again debate for early versus timeless cystectomy. Currently, there are multiple FDA-approved intravesical and the chemotherapeutic agents available. Again, all of these are very good, promising results. But again, for as far as guidelines are concerned, as far as our practicability is concerned, we are rarely using this except for the gemcitabine and docetaxel. This, for exam purpose, at least you should know the name nadofaragine adenovirus. This is an adenovirus which goes into the interferon genes, delivers this the gemcitabine molecule inside the urothelial cells. 75 ml of single dose is given, and then the maintenance schedule. What is important for you is gemcitabine docetaxel with a very promising result, and we are not routinely, but for BCG refractory and also for BCG naive patients, we can use this drug. Again, this bridge trial, which is yet to get completed, will give us a good result. This is a multi-center randomized controlled trial, which will compare the routine BCG versus gemcitabine docetaxel in these high-grade non-muscle invasive bladder cancers. The few futuristic therapies like this TAR 200, in which this is pretzel-like thing which we introduce under cystoscopy guided, and then it in sustained release formulation, it releases gemcitabine. It releases. I think gemcitabine in the bladder. So there are two trials going on. One is Sunrise. Just remember the name: Sunrise for TAR 200, and Moonrise for TAR 200 and 210. So this is edafitinib, used mainly EGFR inhibitor, used again for same thing for non-muscle invasive bladder cancers group. So this pretzel contains an osmotic pump which releases this drug in a sustained formulation, and it can kept for at least 3 months to 12 weeks inside the bladder, and then we remove it. Again, there is something known as adequate BCG, which is defined as at least 5 of 6 doses of BCG, induction BCGs, and at least 2 maintenance BCGs, when we call it as adequate BCGs. Another important thing known as BCG unresponsive tumor. BCG unresponsive again entails few definitions like BCG refractory and BCG relapsing. This definition is important as far as trials are concerned, but in practice we usually use BCG refractory, BCG resistant, and BCG relapsing, and BCG intolerant. So BCG intolerant patients are usually patients who could not get a complete dose because of the intolerability. BCG relapsing or BCG resistant are the patients who get complete response initially, but after a few months or few years, they relapse. And BCG refractory are the patients who don't get any results, or they have persistent disease or recur immediately after the BCG. So again, these few drugs along with BCG to reduce the toxicity of BCG, you can just remember the name: durvalumab, atezolizumab, pembrolizumab, and the newer molecule, which is recently published in 2025 by Nishore and group, is this sasanlimab. These all things are good, promising on paper, but again, I will repeat, in practice, we are not using them. Guidelines also are not supporting them, but in future, maybe in 1 or 2 years, we will definitely be using. So most important for our practice is radical cystectomy. When should we offer radical cystectomy in these particular NMIBC patients, known as early cystectomies? So these are important, very high risk candidates: T1 high grade with CIS, T1 high grade with prostatic urethral stromal involvement, lymphovascular invasion, histologic subtypes, especially the micropapillary or sarcomatoid differentiation, and these BCG refractory cases. In these patients, we should usually not waste time in trying these newer modalities, and we should directly counsel patient for early cystectomies. So this was a very good discussion by Dr. Ashish Kamath, in which he discussed that this T1 high grade, which we usually consider as a non-invasive or non-metastatic disease, is exactly equal like something T3B semanovesical involved prostate cancer with higher grade, with all positive cores and higher PSAs. So the chances of mortality or morbidity associated with this higher risk, high volume prostate cancer disease is exactly what is with the high grade T1 disease of CA bladder. And lastly, to discuss about the variant histologies, whenever we see sarcomatoid, plasmacytoid, micropapillary, these are very high risk and high aggressive features. We should immediately offer radical cystectomies in such cases, in such patients. Also for pure squamous and adenocarcinomas. When we see differentiation like glandular differentiation, squamous cell differentiation, nested variant, we can follow the same protocol that we follow for urothelial malignancies, like TURBTs followed by intravesical therapies, and then we can offer them radical cystectomy at the end. And for small cell, we should go for neoadjuvant chemotherapies followed by radical cystectomies. So these are the newer trials which are in horizon. Few are completed, few are yet to be completed. At least for few trials, we should be aware of the name and the molecule tested. So my final slide about the learning points. Most important thing is complete TURBT. Risk stratification, especially for intermediate risk, the IBCG has differentiated them into the 3 sub-classification depending upon the risk factors. There are multiple newer intravesical therapies and many trials which are going, which have very promising role. But as far as practice is concerned, or as far as your exam is concerned, whenever the patient has BCG unresponsive or very high risk features, the answer in exam should be radical cystectomies. Thank you so much.
Thank you, Saurabh, for the excellent presentation. I think a lot of concepts have become clear for students. Should we take the case now? Or anybody has any questions for Dr. Saurabh?
Saurabh will be answering, asking the question and answering. So, Hiren, when we
Yes,
start
sir.
the case,
Yes, sir.
Saurabh also will be there.
Yes, sir. Yes, sir.
Yes,
He's
sir,
there,
I'm
sir.
here.
He's there, sir. Okay. Saurabh, we'll start the case then. Huh?
Yeah.
Yes, sir. I'm
Rahul?
doing.
Yes.
Yes.
Okay. Saurabh, we can stop sharing your slide.
Yeah. So there is one question I can see in the chat group, the difference between timely and early cystectomy. A very good question. So early cystectomy is a cystectomy that we offer in T1 cases, which are very high risk, or for variant histologies for that matter. So, and timely cystectomy is for T2 cases in which we can try other modalities, but we are offering radical cystectomies. So timely cystectomy is for T2 diseases, and early cystectomy is for T1 diseases which have very high risk features.
Who is answering today?
Sir, there are total 3 participants today, sir. We have Dr. Mukani Velan, Dr. Shashank, and Dr. Karan, sir. I guess they have joined, sir. Can we start, sir?
Yes, please go ahead, Rahul.
Yes. A 56-year-old male presented with complaint of reddish discoloration of urine since 2 months, passage of blood clots in urine since 1.5 months, and increased frequency since 10 days.
Go ahead, students. What else you want to ask?
Yes, sir. Good evening, sir.
Yeah, good evening, Shashank.
Sir, I would like to know further details about this, sir.
Ask him what you want.
Whether this was a painful hematuria or painless hematuria, complete hematuria, or was it related to the act of like initial complete or terminal hematuria.
So, Shashank, when you ask details about hematuria, I think that you should have something in your mind, some protocol. You start with painful, painless, total, initial, terminal, clots, no clots, whether any other symptoms, pain abdomen, fever, constitutional symptoms. So have one set of in your mind what all you want to ask regarding hematuria so that you don't miss it in the exam.
Yes, sir.
Rahul, give them the details, whatever he wants.
Patient was asymptomatic before 2 months, after which he started having complaint of reddish discoloration of urine. It was at the end of the maturation, insidious in onset, gradually increasing, painless, no specific aggravating or relieving factors, amorphous shape. Reddish discoloration was associated with passage of clots since 1.5 months, and patient also complained of increased frequency since 10 days, which was associated with mild burning sensation, decrease in flow, and straining while passing urine. Patient gave history of similar episode 1 year ago, which subsided spontaneously. The IPSS score is 11 out of 35, sir, according to the symptoms.
Finish the history.
Go ahead, Rahul.
This was the picture presentation, the way patient had complained of. The patient does not have any history of abdominal pain or dysuria, lithuria, pyuria, no history of urgency, incontinence, or urinary retention, no history of previous instrumentation or catheterization, no history of nausea, vomiting, fever, no history of jaundice, facial puffiness, exertional breathlessness, or lower limb edema, no history of backache or bony pain, no history of bleeding disorder, anticoagulant therapy, or blood transfusion, no history of radiation or chemotherapy, sir. Shall I go ahead, sir?
Yeah, go ahead.
Past history. Patient is a known case of diabetes and is on metformin 500 milligram BD since 3 years. Family history is non-contributory. Personal history. Patient takes vegetarian diet. Appetite is normal. Bowel is regular. Bladder is disturbed as described, sir. Sleeps are normal. Habits. Patient is a social drinker, non-smoker, non-tobacco chewer. Patient works in an office, sir. Just occupation history, sir, of the patient.
Why occupational history is important?
Sir, especially in case of hematuria where carcinoma bladder is suspected, there are certain high-risk occupations, sir, where they are working in rubber industries, paint industries, which are associated with higher risk of carcinoma bladder.
Good.
Petrochemicals.
But yes, yes.
Next.
Can I go ahead, sir?
Yeah.
Go ahead, go ahead.
So now what they want.
Yeah. Shashank, now what will you do? Sir is asking, what do you want?
Yes, sir. With the history, sir, I would like to have a provisional diagnosis of bladder growth in this patient, sir. So I would like to examine the patient before going
Why
for
why only bladder cancer? Why not any other? Only one differential diagnosis.
No, sir. My differential diagnosis one is bladder growth, sir. It can also and other differential diagnosis can also be there in this patient, sir.
Like what?
Uh, renal cell carcinoma, sir,
Mm-hmm.
or a stone disease, sir, like vesical calculus, because it is also associated with irritative lower urinary tract symptoms here. I would also do.
Storage LUTs, you mean?
Yes, sir.
Use the correct terminology.
Yes, yes.
Obstructive and irritative was the old terminology.
Yes, sir.
So definitely you have to think of other things also. Sometimes, many times we all have seen renal tumors with frank hematuria, and patient may not have pain or may have clot colic.
Yes, sir.
Okay. Now what will you do?
I would like to examine the patient in this case, sir.
Rahul, give him examination.
Yes, sir. Patient was examined in a well-lit room with proper consent. Patient is conscious, cooperative, and well-oriented to time, place, and person. Pulse is 76 beats. Blood pressure is 132 by 76 millimeter of mercury. Respiratory rate is 18 per minute. Afebrile. Patient SpO2 98% on room air. No evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Spine examination is normal, sir.
Genitals,
Yes, sir.
you must always tell, no?
Sir, should I go ahead, sir?
Go ahead, go ahead.
Yes. On per abdomen inspection, sir. Flat abdomen, centrally placed and inverted umbilicus. Normal abdominal thoracic respiration, sir. Skin of the abdomen has no scar, sinus, or dilated veins. There is no visible swelling or renal angle fullness. There are no visible peristalsis or pulsations. The hernial sites are clear. External genitalia is normal, sir, uncircumcised.
Okay, Shashank, now what?
Yes, sir. I would also do a digital rectal examination to complete the examination, sir. Followed which I would like to uh, do an ultrasonography of the kidney ureter bladder as a completion of my examinations as a part of
Very
my.
good. You did remember that patient had LUTs. So
Yes, sir.
definitely rectal examination is a must. Rahul, was it done?
So first, palpation, sir.
Go ahead. Give him.
Sir, normal temperature, no tenderness, no
All
obvious.
this is normal, na? Then next.
Yes, sir. Okay. Per rectal examination, no fissure, fistula, or hemorrhoids. Anal tone is normal. Prostate grade 2 enlargement, firm in consistency, smooth surface, non-tender, median sulcus obliterated, no nodularity or induration. Rectal mucosa is mobile, rectum empty, no blood on gloves, sir.
Okay. So Shashank, this is what he has given you. So now you would like to have an ultrasound examination?
Yes, sir.
That's it? Anything else?
No, sir. I would also like to have a few investigations, sir.
So tell
Like,
him now what you want.
yes, sir. A complete blood count, sir, in this case, which to see for hemoglobin.
Definitely. He's been bleeding for some time, no? So why you asked only ultrasound? So in one breath you say you want CBC, urine routine, something creatinine,
Yes, sir.
ultrasound. What all you want, you tell him.
Yes, sir. I would like to ask for complete blood count, a renal function test, urine routine and microscopy, uh, urine. I would also ask for urine cytology, sir.
For cytology, what you will be careful? Is he bleeding now?
No, once if there is bleeding, the
So
synthetic
that
is.
you have to ask him, no? You have to ask. If patient is bleeding, then there is no point doing cytology, no?
Yes, sir.
So you have to say that, huh? Before
Yes.
examiner asks you.
Yes, sir.
And what else? Ultrasound.
Yes, sir.
Rahul, give him.
Sir. These are the blood investigations of the patient. Hemoglobin is 10.3. Total count is 8,580. Serum creatinine is 0.73. Coagulation profile is normal, sir. Serum sodium is 141. Potassium is 4.5. HbA1c is 5.2. PSA is 3.4, sir.
So Shashank, are you happy with the PSA or you didn't want it?
PSA is 3.4, sir, here.
Did you want it or you didn't think of it or you didn't want it?
In this case, clinically, it was digital rectal examination was normal, sir. And
Right.
also, yes, sir.
Okay. Ultrasound.
Yes, sir.
Go ahead, read it.
Yes, sir. These are the ultrasound films of the first image seems a moderately distended bladder, sir. And there is one probably a broad-based growth arising from. I would like to ask for the location.
No. This is the way you will read.
Villani, you can also answer, huh?
You are just jumping directly to bladder, no? You should say ultrasound of the KUB region, sir. What I can see is the bladder and the kidney.
Yes, sir.
Both the kidneys you can see, right?
Yes, sir.
You only said differential diagnosis RCC. You don't want to comment about the kidney.
Yes, sir. Yes.
Then why are you jumping to bladder? See, if you do like this in exam, they'll think you know the case. Huh?
Yes, sir.
Whenever any investigation is given, you should read it fully, no?
Yes, sir.
Whether it is ultrasound, CT, whatever you see, gallbladder, liver, pancreas, gallbladder, everything. Whatever you see, you must say.
Yes, sir.
Okay. Now, what are you seeing here, bladder? What are you saying?
Bladder, there are multiple lesions arising from the wall of the bladder, sir.
Hmm.
Look like a broad-based growth, sir.
How you said broad-based? I don't think, is it appearing broad-based?
Because in the images, it doesn't look like a pedangulated, sir. It is the base is broad, sir.
So would you want to know the size? Why
Yes,
is the size important?
yes, sir. I would like
Why
to.
is broad base important? Why you're saying broad base?
Mm,
If
It
it is
also,
broad base, is it important? Why is it important?
because depending on the base and the size, sir, we can uh, like we can indirectly come to know whether it's.
So what are those features that tell you that it could be a high grade or an invasive tumor?
Sir, one is the broad-based tumor, increased size of the tumor.
So broad base more than 5 centimeter or maybe 3 to 5 centimeter.
Yes, sir.
Then
Associated with
multiple tumors,
hydroerythronephrosis.
yes.
multiple tumors, tumors located at the trigone,
Mm-hmm. Something going grossly outside the bladder. Also, na?
Yes, sir.
If you see a mass going outside the bladder, definitely it's a high grade invasive tumor.
Yes, sir.
Okay. You want the report?
Yes, sir.
Saurabh, you want to throw some light on this?
No,
Anything you want to add extra?
everything is perfect, sir. Only thing is, my question was to Shashank. He said clinically it was not looking like like suspicious for prostate cancer, so PSA is not required. But whenever we see patient more than 60 years in practice, obviously as per guidelines, with some LUTs, we have to do PSAs. So it is for opportunistic screening.
So Shashank, whenever the
Yeah,
question
so
was
there is a
asked,
role
like
of
I
PSA.
asked you, yeah, Shashank, I asked you, were you happy with the PSA or no? So you said examination was normal, but if you want to say that you want to ask for PSA, you have to justify like how Dr. Saurabh said.
Yes, sir.
Okay, so you must be ready with the answer.
Yes, sir.
In the exam, you have to defend yourself, whatever you say.
Yes, sir.
So, but it is important that because the patient is more than 60, he has some storage LUTs.
Yes, sir.
Okay.
Yeah, so next, what you want now?
Share the report, Rahul. Read it fast. Important findings.
Yes, sir. Kidney, gallbladder is well distended and few tiny calculi are seen in the GB lumen. Spleen and pancreas are normal, sir. Kidneys,
Important findings, Rahul.
yes, sir.
Fatafat.
Fine. Yes, sir. Focal thickening and mass lesions seen in the urinary bladder wall, suggestive of neoplastic etiology, needs further correlation. Fatty liver grade 1, cholelithiasis, left renal calculi, bilateral concretions, and prostatomegaly, sir. Prostate volume is 34 ml, sir.
See, kidney, there was a stone, no? You were missing the kidneys and going ahead.
Yeah,
Shashank.
so these are the findings. Now, what you want?
Yes, sir. There are multiple.
Belani, what you want now? You want anything or you want to do a directly scopy?
No, sir. Since there are multiple tumors are there, we'll go ahead with the contrast enhanced CT of the kidney and bladder, sir.
CT urogram, sir.
Yes.
And also urine
Karthik, what you want?
Sir, I would like to go ahead with a CECT of the abdomen pelvis region with a CT urogram with specifically focusing over the delayed images.
What
Why
will
not
you
to
look
do?
for in CT scan?
Sir,
What are you expecting from CT scan?
yes, sir. In CT scan, as part of evaluation of the bladder, sir. Along with that, I would also look for the upper tract lesions, sir, in this case,
Good.
and
Good.
also for lymph nodes.
Okay.
So what is the ratio between upper tract to lower tract and lower tract to upper tract?
Sir, there can be concomitant lesions in the upper tract, sir, in case of bladder growth of around 15%, sir. So we need to rule out the upper tract lesions which may be associated with this bladder growth.
And upper tract to lower tract?
Yes, sir.
Concomitant lesion?
Yes, sir. Upper tract.
Sir.
So now if both are present, how will you find out which one is come first or something? Okay, Brijesh, show them CT scan.
Yes, sir. There are multiple plates, sir. Once you can tell me when I can move on, sir. Shall I change, sir?
Yeah, change it. Karan, can you read it?
Yes, sir. Sir, this is the contrast enhanced CT scan of the abdomen pelvis region. Sir, in this scan, we can see that both the kidneys are looking normal, sir. There is no evidence of any hydroeritonephrosis, and the liver also appears normal, sir, in the scan. When coming to the bladder, sir, we can see multiple growths in the bladder, sir. In the delayed phase, we were able to see filling defects in the bladder, especially on the left anterolateral, right anterolateral, and also the posterior wall, sir.
Can you show the first image again? I did not see any filling defects. Yes, it is visible. Okay.
Shall I change to second, sir?
Yeah.
This is the third plate.
Sir, I'm not able to appreciate any significant lymphadenopathy in the current films, actually.
Rahul, I think we need to present these images better. You need to show the important images and magnify them properly.
Yes.
I don't think anybody will be able to read these CT images. Means even I could see just one single filling defect and a single nodule in the wall, and there is no way anybody can comment on lymph nodes on these images.
I totally agree with you. So next time we will be showing only those relevant, X-rays or
So maybe you can show all the images and then show important images in the magnified
important.
format. Yeah.
So Rahul, here also you can just magnify only those 2 or 3 slides which we have seen it earlier.
Yes, sir.
Okay, Rahul, you can just read the report.
Multiple small, poorly enhancing soft tissue lesions showing marginally to the on the left lateral wall of the urinary. Am I audible, sir? Sir?
Yes, Rahul, go ahead.
Yes. Multiple small, poorly enhancing soft tissue lesions showing irregular margins are seen adherent to the left lateral wall of the urinary bladder endophytically, with similar smaller lesions in the right paramedian bladder outlet. The bladder lesion measures approximately 1.6 by 1.1 centimeter, seen in the left superlateral wall of the urinary bladder. Another lesion of 1 by 0.8 and 8 centimeter and 8 by 5 millimeter in the left paramedian lateral bladder wall in the interior aspect. On MRI screening, these lesions show prominent diffusion restriction with low ADC. Overall findings of these lesions are likely suggestive of multifocal neoplastic etiology, possibility of TCC. Prostate is mildly enlarged in size and measures 4.3 by 5.5 by 4.7 centimeter with median lobe indentation. A couple of tiny microcalculi are seen in the dependent portion of the gallbladder. Minimal bilateral perinephric fat stranding is seen due to mild retrograde UTI. Small indefined fat stranding with intralesional subcentimetric size nodules are seen in the upper abdomen mesenteric fat, overall measuring 9.6 by 4.4 by 6.4 centimeter in size, likely suggestive of mesenteric paniculitis. Appears incidental finding. A couple of small bilateral renal simple cortical cysts are seen, approximately 6.8 millimeter in size, radiodense calculus. Approximately 6.8 millimeter size radiodense calculus is seen in the lower calyx of the left kidney. Elsewhere, both kidneys show normal contrast enhancement and excretion on early and delayed urogram phase. Both kidneys are normal in size, position, and thickness. Otherwise, the urinary bladder is normal with normal wall thickness. Bilateral renal arteries and veins appear unremarkable. Rest of the abdominal viscera appear unremarkable. Yes.
Yeah. So Shashank, can you just summarize what is given in the CT scan?
Yes, sir.
Just summarize.
Yes, sir. There are multiple bladder growths, sir. Here, largest measuring of around 1.6 centimeters with normal upper tract, sir, and with no significant lymph nodes, sir.
So what is next investigation that you want?
I would like to get a diagnostic cystoscopy and EURBT in this patient, sir, both as for diagnosis.
Okay, any role of cytology here?
These are multiple tumors, sir, and yes, sir, urine cytology.
So what? If it is multiple, then we should not do cytology.
No, sir. The it's high grade tumor. It's more likely to be associated with high grade tumors, sir.
Dr. Pushkar, please mute yourself. There is a lot of background noise. Dr. Pushkar.
Yeah. Okay. So will you advise cytology or not?
Yes,
and
sir.
why not?
Yes, sir.
Yes,
I would
sir.
like to, but I would like to ask whether hematuria is persisting, sir. If
okay, hematuria is stopped.
Yes, sir. I would like to ask for urine cytology.
Benefit?
The sensitivity in this case, if it only adds to the diagnosis, sir.
How? You are
It
anyways
detects
going
high
to go
grade.
ahead with and take out the biopsies. So what additional benefit you will get from doing cytology?
As
We'll
a,
come to know pre-operatively whether it
no
is a high
additional
grade or
benefit
not.
as such in this case, sir, because
Sorry?
there is obviously in the there is obvious finding in the imaging, sir, with multiple growths. But
Imaging is okay, but
No. Sir is asking you how it is going to help you.
will you change
What
your
should
plan
be
of
the answer?
management? Will you be ready for something? Will you discuss something with patients? Is the cytology going to get you some extra information and change of plan of management in your practice?
So positive cytology suggests something, negative cytology doesn't rule it out.
if high
Positive
grade,
means
So if cytology is positive, that means it is more likely to be high grade. Obviously, it is a high grade. Okay, and if you do biopsy, it turns out to be low grade, for example. That means either pathology is not correct, one thing, or you are not having complete diagnosis, or you are missing something. Maybe a
yes,
tumor in the prostate urethra, which you have missed, or maybe a tumor in the upper tract.
yes, sir.
So cytology is, as far as at least for exam point of view, you should ideally say cytology.
Yes, sir.
Okay, go ahead. So how will you manage now?
Sir, I would like to proceed with diagnostic cystoscopy with transurethral resection of bladder tumor, sir.
Okay.
So for that, I would like to ask for if planning for spinal anesthesia with obturator block, or better to plan under general anesthesia.
Okay.
Because these are the size of the tumors are largest measuring 1.6 centimeters, sir. You can
Mhm.
also plan for unblock TU or BT, sir. If laser is used, then the risk of obturator jerk will be minimized, sir.
Perfect. Okay. What will you look? How will you plan your cystoscopy and TRBTs? Important 2-3 factors.
Sir, we have to see for the urethra and also the bladder, sir. In
Very
the
good.
bladder, we have to mark the lesions using as per AU
Correct.
numbering
In
in, sir.
systematic fashion. Correct.
And we have to systematically see for all the lesions, sir, and also see for the flat lesions, any red patches are there, and also
Mhm.
see for the ureteric orifices.
Correct. Very good. And the efflux of urine.
Yes, sir.
Good. Okay. So Rahul, you have cystoscopy picture or the pathology report?
We have the pathology report, sir.
Okay. Go ahead.
Yes, sir. Deep muscle biopsy from the tumor on the left wall of the urinary bladder, and superficial biopsy from tumor on left wall and bladder neck was taken. Gross description is as described, sir. Microscopic description, the section 1 shows fibromuscular tissue free of tumor. Section from second specimen shows features of high-grade papillary urothelial carcinoma, but lamina propria invasion is not seen in the submitted material, sir.
Okay. So what is your diagnosis now? Pathological diagnosis.
It is a non-invasive papillary carcinoma, sir.
Pathologically diagnosis.
EA,
TA high grade.
Sir,
TA high grade.
high grade PTA, non-muscle invasive bladder cancer.
Okay. So what is the next step in your management?
We have to risk stratify the patient, sir. In this
Okay.
case, because it is a TA high grade and multiple tumors, sir.
Mhm.
I'd like to classify as it is not TA, it is a low risk tumor, sir.
Low risk. How? What are the criteria in low risk groups?
It should be a TA less than 3 centimeter with no CIS.
Low risk. You are saying low risk, right?
Yes, sir.
But this is high grade.
High grade, yes.
Then how come is it?
No,
It is low
it is,
risk.
sorry, sir. This is a high risk
High risk.
because it is high
High
grade.
risk.
Correct.
Had multiple tumors, sir.
Mm-hmm. So this is high risk basically.
High risk, yes, sir.
Yes.
Okay. So what is the next step?
I would
We
also
have to
like
plan
to
for
Yeah, others can also contribute. बेचारे शशांक की एग्जाम हो रही है.
Even low risk multiple tumor
Can
becomes intermediate, no?
Yes, sir.
So
Yes.
then why did you say?
Yes, sir. Sorry, sir. This is high risk.
This risk stratification is very important. You should just by heart it.
Yes, sir.
In practice also, in exam also. Okay, next step.
So intravesical, yeah. As after TURBT, I would like to give one dose of mitomycin C, sir. Here, like as a part of after TURBT, one dose of
Okay.
mitomycin C of 40.
Yeah, accepted. So so again, if you have done urine cytology, if your urine cytology had shown you positivity, then it is high grade. Then no role of intravesical MMC. Okay, that's why urine cytology is important,
Yes, sir.
right?
Yes, sir.
Correct. So when will you plan for intravesical MMC, immediate dose of intravesical MMC, mitomycin C? In which cases?
Sir, even in low risk tumors,
Low
also
risk.
there is indication of one dose of mitomycin C, sir.
Which cases you are doing cystoscopy? You have to decide it in the perioperative period within 6 hours.
6 hours.
So which picture will you decide for intravesical immediate dose of intravesical mitomycin C? You don't have pathology report after cystoscopy. I am saying.
Yes, sir. Multiple based on the characteristics of the tumors.
Like
Multiple tumors, broad-based tumors.
in which you will give mitomycin.
No,
Rather
sir, we will
ulta.
not give this.
Correct.
We will not give. We have to single.
So role of single dose mitomycin in immediate perioperative period is for low risk and to some intermediate risk cancers. So they have to be a single, sometimes multiple, but smaller lesions, papillary looking, non-solid, usually less than 3 centimeter, and with negative urine cytology. So these are the ideal candidates for planning immediate post-operative intravesical chemotherapies. Okay.
Yes, sir.
Okay, so you have risk stratified this patient as a high risk patient. What is the next step?
We have to plan for restage TRBT after 4 to 6 weeks.
Very
this
good.
patient.
Okay, and what are you expecting? Why are you doing it? You have done this TURBT. You know you had done a complete job. You have done a good job. Then also you want the restage TURBT.
Yes, sir. Still, I would
Why?
like to go ahead with the restage because there is chance of upstaging, 30% chance of upstaging there in the restage TRBT. So that's why I would like to go ahead with the restage TRBT.
Very good. Correct. Okay. So Rahul, what is
Yes,
the
sir.
next thing?
Sir, this was
And
the
also
end of
muscle
the.
is this histopathology. They have not given about muscle also, right, sir? Muscular
Muscle
dystrophy
they have
not
given
given.
now. They have given fibromuscular tissue which is free of tumor.
Fibromuscular.
What is important one more thing important here is lymphovascular invasion.
Yes, sir.
If it is present, it is a high risk feature, very high risk feature.
And also we have to look for concomitant CIS is also present or not.
CIS, yes,
Okay.
correct. Theoretically, yes, but in Indian practice, we hardly see CIS. But yes,
Okay.
CIS, lymphovascular invasion, these are important prognostic factors and can change your plan of management. Okay, next. Restage kya hai, Rahul?
No, sir. The patient is yet to come for follow-up, sir.
Okay, no problem. So what is the next thing?
We
Sir,
have to do
next.
restage TRBT and
हो
follow
गया
up the weather.
Okay. So what is next, Rahul? क्या है slide में?
Sir, this was the end of the first case, sir.
Okay. So, okay, you have done restage TURBT. It is the same. So, sorry, cystoscopy was negative. There was nothing inside. You had done a good job. Then what?
Sir, I would like to consider intravesical BCG in this case, sir, because it's a high risk.
Okay, correct. Then
after 2 to 4
how
weeks,
is the schedule?
Yes, sir. It starts after 2 to 4 weeks of tumor resection, sir. And
Okay.
there is an induction phase and maintenance phase, sir. Induction phase for 6 weeks, weekly doses for 6 weeks, followed by maintenance phase, sir. There are two schedules.
How much BCG? You have to tell completely the dose also.
It is
81 mg in 50 ml NS.
Sorry?
80 milligrams.
81 mg in 50 ml NS, sir.
Okay, so you should tell it is ideal dose is 120, but we can use 1/3 or 2/3 doses in practice. Usually, we use 80 milligram once a week for 6 weeks induction. Yes. Then
the maintenance phase, sir, there are two regimens which are available. One is the SWOG regimen and LAM regimen.
okay.
So SWOG regimen, 3 weekly doses at 3 and 6 months, and after that every 6 months for 3 years, sir.
Correct.
If it is LAM regimen, after induction regimen, 1 dose per month for 10 months.
So once you start telling about BCG, everything you should tell. The regimens, what are the doses? Like sir said, you can use less dose in clinical practice. What is the strain we are using? Everything you should tell.
Yes, sir.
What strain is there?
Mexican strain we are using, sir, in India.
Sorry?
Mexican strain, sir.
Earlier
Sorry,
we were using
Moscow strain. Moscow strains.
Earlier we were using Danish
Danish
1331,
strain, now
which
we
is
changed to Moscow
now it
strain.
is. Yes, yes.
Okay. So next case discuss करना है. Rahul, next case.
Yes, sir. Yes, just a minute.
Okay, so before starting BCG, what will you check in the history and examination for a patient?
One thing is any
active UTIs there are not, sir?
Sorry?
Bleeding
active
and
UTI.
UTI, sir.
Correct. Very good. If there is an active UTI, then?
So we have to treat the UTI before giving BCGs.
With
It's a contraindication, relative contraindication.
Okay. Okay, you have treated the UTI, you have started BCG, and patient is having severe LUTS. Then what will you do? UTI is cleared now. There is no active UTI.
Severe LUTS without fever.
Yes, without fever.
So it's a class 1 BCG, this one's a complication. So just we have to give symptomatic management, give NSAID, anticholinergics, we have to give for the patient, sir.
How can we improve the efficacy and tolerability of, mainly tolerability of BCG?
So by reducing the dose, sir.
Okay, good. Correct. Then like you rightly said, we should focus on the symptoms. We should also assess the other things like PVR, okay, previous LUTS. We should, if the patient, for example, this patient, more than 60 years, usually we should start them on alpha blocker treatments. Usually they are already on alpha blocker treatments, but we should also assess the LUTS component. If PVR is high, then again same thing, we should ask them for a complete voiding. If not, then we should put catheter and empty it, make sure that it is completely emptied. If patient has diverticulum, then a patient has a diverticulum and you saw a tumor in the diverticulum, a male, same patient, for example, a 60
so
60
that is
plus.
directly, so we have to go ahead with the cystectomy, sir, for that patient. Because
Why?
there is no muscle in the diverticulum.
What is true diverticulum and what is false diverticulum?
So based on the cystoscopic picture, we can make a call, sir. If it appears like a low-grade tumor, we can go with resection and fulguration at the base, sir.
Correct.
And it appears like a high-grade tumor, we can go for resection with like extensive resection, little extensive resection.
Okay. And I think Shashank said directly cystectomy, right? Who said cystectomy?
So I said cystectomy, sir.
Okay.
Because
Achha. So why cystectomy directly without assessing the grade, without assessing the histopathology report?
so,
And do all diverticula have no muscle in their wall? What is true diverticulum? What is false diverticulum?
true diverticulum, it lacks the muscle layer. So in that case, directly it,
Okay. And in elderly
applies.
people with large prostate, secondary changes, secondary diverticula, what are they? They do have muscle, right?
Do have muscle lacks,
Yes, correct. So we should not directly go ahead with cystectomy. Maximum what few AUA guideline recommend is diverticulectomy. But again, it is also an extra treatment. Obviously, no cystectomy. You should resect. If it is not possible, it's a large tumor, then diverticulectomy has been recommended. And go ahead with your intravesical plan. Okay,
But
you
how do we
did.
assess
Sorry.
clinically? I mean, how do we know that whether it's a false or this one diverticulum? Just by
So you do, yes. So mainly on patients, for example, an elderly patient with large prostate with LUTS likely to have secondary diverticuli. Younger patient, female, usually have primary diverticuli. Primary diverticuli are usually from younger ages. Then you take a biopsy, you can see the wall sometimes. You take a superficial cut, you can make it out sometimes. On MRI or on CT scan also, you can sometimes get an idea about the wall. Whenever they were divertical, you can do an MRI. So wall thickness you can assess on MRI.
okay.
Okay. One more scenario, you did cystoscopy and there was a tumor exactly sitting on the ureteric orifice. What is your plan?
We can resect that using a
We can
pure
resect.
cutting current, sir.
Okay.
And then also we have to take, we have to see for the upper tract, sir. Urine.
You resected it. Now you can't find the orifice. Now what will you do?
Yes.
Would you like to put a guide wire or something before? Or would you like to use a ureteroscope to go inside and see how big the tumor is?
Yes, sir.
So you have to think before resection. You have to think. Later on, you may not find the tumor or find the orifice only.
Yes, sir.
And also, you have to be careful while resecting. What will you be careful of?
Obturated jerk.
No, not try to use too much coagulation current. Otherwise, the orifice will close.
Yes, sir. Pure cutting current will use in resected.
Okay, go ahead. Sir was asking some question.
Will you put stent in these patients? You have resected the ureteric orifices with pure cutting or whatever measure you have taken. You have done a good job. But you have resected the ureteric orifice. Now, will you put stent?
No stenting, sir.
Why?
So by putting a stent, since after the resection there will be release of the tumor cells into the bladder, there is higher chances of tumor seeding, and due to reflux due to the placement of stent, it can go into the upper tract. And
What is the percentage of tumor seeding in upper tract from lower tract in such scenario with stent?
Very less.
Means, so it is 7 to 8%. Again, yes, routine stent is not recommended. When will you put stent? When will you be 100% sure that I don't want to put a stent, and when you will be in doubt that I should put a stent? Or in all patients you will not put a stent? So
when
if
there
your
is
depth
no,
of resection is not too deep,
yes,
if you can see the efflux, if you can see the mucosa pouting out, then you can just wait and watch. You can go ahead without putting stent. Anyways, you are doing surveillance cystoscopy or restage cystoscopy. At that time, you can just get an ultrasound done, see for hydronephrosis. That time also you can put it. But if you have gone too deep, if you are not sure about the mucosa pouting out, if you have by mistake used monopolar or cautery current, coagulation current, then ideally you should put stent. The chances are less than 10% of upper tract seeding.
so
Okay.
if a patient presents with a growth near with either of the ureteric orifice with say moderate hydroureteronephrosis, and we do the resection, is placing a stent recommended, sir?
So again, same thing. If the tumor is inside the ureteric orifice, okay, you have resected it completely. You can see if there is no growth left. If the efflux is good, mucosa is pouting, no need for stenting. But if you are going inside ureter and see again, if you are taking biopsy completely, then no need for stent. Stenting is done just to prevent ureteric orifices, not stenosis.
Okay, thank you, sir.
Sir, I just wanted to ask one question, sir. During when a case is presented like a patient with gross hematuria and bladder growth, in exam, should we go ahead with CT urogram in all cases or upfront TURBT in some cases, sir? How is it?
Okay, so less than 3 centimeter masses, single solitary less than 3 centimeter mass with negative urine cytology, you can go ahead with TURBT. But safe answer is always CT urography, because you are also telling that examiner that you are aware about the upper tract incidences, concurrent simultaneous upper tract changes, the depth, the lymph node, everything you want to know. But again, in smaller single less than 3 centimeter negative cytology, you can go ahead, you can justify.
Yes, sir. Thank you, sir.
Now, in the last case, if you saw, the sonography showed that there was a stone
Yes, sir.
also, and there was gallbladder stones also, and there were multiple tumors. So, if you ask for CT, you should be able to justify, how to justify your answer.
Okay, sir.
Okay, next case.
Yes, sir. It is a short case, sir.
Go ahead, Rahul.
A 66-year-old male patient was diagnosed with carcinoma of urinary bladder with grade 2 prostatomegaly, for which he underwent TURP and TURBT at his hometown in the year 2023. This was the cystoscopic findings of the patient. Anterior urethra is normal, moderately elevated bladder neck, mildly trabeculated bladder with 3 to 4 small superficial sessile lesions at the posterior wall of bladder. Bladder capacity and bilateral ureteric orifices are normal. Shall I go ahead, sir?
Okay, just Karan, now this is the finding, what we will do.
Sir, if the patient has LUTS secondary to the moderate elevation of the bladder neck, along with the transurethral resection of the sessile lesion, sir, we can do a bladder neck incision or resection of just the median lobe, because the lateral lobes don't appear obstructive, sir.
I didn't understand. You'll do only median lobe because you're worried of seedling or what? When you're doing TURP, why you'll not do full TURP?
No, sir.
What are you worried about? You're worried about doing TURP and TURBT together?
Sir, in the cystoscopic finding also, they have not mentioned really about if there was enlargement of the prostatic lobes.
No, the question is whether you will do TRP and TRBT together or you will differ. You will not do it.
Sir, TRP and TRBT actually, sir, it is not recommended to do it together, sir, because there is a risk of tumor seeding to the prostatic stromal, sir.
Do you have any study on that? Then, Saurabh, please throw some light on.
So I think I think he's right. We can do simultaneous TURP, TURBTs. I think we can go ahead.
No, he's saying that he's worried about the tumor seeding. That's why that question came. So what Saurabh is also saying and what Sir is also saying, that there is no problem. You can go ahead and do it. Okay.
Yes, sir.
Even if it looks like a high grade also, we can go ahead, sir.
Yes.
Okay, Rahul, show the report.
Yes, sir. This was a histopathology report, sir. First is TUR bladder tumor. A section show papillary tumor with central fibrovascular cores with multi-layered transitional cells, loss of polarity, nuclear pleomorphism, rounding of nuclei, and loss of linear orientation of cells to basement membrane with rare mitosis is seen. Minimal invasion in lamina propria. The second section of TUR prostate shows small to large glands lined by columnar epithelium. Few glands show secretion in the lumen. Smooth muscle cells of stroma show hypertrophy, lymphocytic cell infiltration in the fibromuscular tissue. No malignancy seen. The impression is of a low-grade papillary urothelial carcinoma with benign glandular hyperplasia of the prostate, sir. Shall I go ahead, sir?
Shashank, what will you do now?
Yes, sir. Intravascular, on table after transurethral resection, I would like to see for a role of mitomycin C here also, sir.
If you have done a TRP, you want to put a mitomycin, you don't mind.
With TRP, yes. Sorry, sir, I'm not sure.
Of course, there is no problem. Saurabh, just tell.
So sorry, what did you ask?
Patient is undergone TRP, whether to put a mitomycin on it.
I did not get your question. What? Underwent TRP?
TURBT with TURP, sir. Whether there is any kind of mitomycin C, if the patient has undergone TURP also.
So if there is no active hematuria, we can give within perioperative period. If active hematuria, then we should ideally not give.
So the Shashank, next question is when you will defer putting mitomycin? In which other cases after resection?
If there is any suspicion of perforation, sir, or active hematuria, we will not give mitomycin C.
Okay, so what is this next step for this patient? What is the risk stratification? This is recurrence, right, Rahul?
Low risk.
No, sir.
The first time?
Yes, sir. First case, sir. This was in 2023, sir.
Okay. Okay.
So whether patient underwent any follow-up cystoscopy, we have to ask for this patient after at 3 months. So low grade papillary. We have to ask that history, sir.
Okay. Next, Rahul.
Yes, sir. Post-operatively, he was started on intravesical instillations of BCG vaccine, in which he was given a 6-week induction course, followed by 3 weekly instillations at 3 and 6 months, and then every 6 months till date, sir. 2 months ago.
Okay, wait. Are you happy with this, Shashank or Velen?
No, sir. For low risk, he was given BCG. BCG, sir.
Correct.
Sir, I would like to ask one question, sir. Sir, like in the HPU report, they have mentioned that there is a minimal invasion of lamina propria, and you had told that low-grade T1 we very usually see. So
it was T1 or TA in this case?
So that's what they've given, minimal invasion of the lamina propria. So will it be PT
Right.
or PT1, sir? How should we consider whether to?
Okay, so ideally we should review this pathology report, because most of the oncopathologists, even Tata oncopathologists, and if you have seen in conference also, it has been discussed, most of the time the low grade are not invasive. If it is T1, then it could be either high grade or it could be a low grade TA. Obviously this can be seen, it is not a absolutely no scenario, but usually whenever you are saying this, you should ideally get it reviewed from an expert or experienced pathologist. If he or she is also saying the same way, then obviously it is low grade T1. Then it is intermediate risk. As per AUA classification, as per EAU, it becomes high risk because it is T1.
Yes, sir.
Then again, what should have been done in this case?
Intermediate means that maintenance should be at only for 1 year.
No, restaging TURBT, right?
Restaging TUR.
Correct. And then if it is really T1, confirmed T1, then yes, BCG is okay. But low grade T1, we can go ahead with chemotherapy first. We can reserve the BCG for later usage.
Yes, sir.
Okay, then. So BCG is complete. 6 weeks induction followed by maintenance, 2 maintenance, right?
It's
Or
continuing
complete.
till date.
6
Every
months
6
till
months.
date. Okay. Okay, complete. Okay, then go ahead, Rahul.
Yes, sir. 2 months ago, he presented with severe right flank pain, and USG was done It was suggestive of right-sided gross hydronephroureterosis. He was posted for cystoscopy and following findings were seen. Shall I show the findings, sir?
Please go ahead.
We don't have a picture, sir. I have the report for it. Mild bladder neck contracture with which was dilated, small capacity bladder, approximately 250 cc. Left ureteric orifice is normal. Right ureteric orifice was not visualized. Scar tissue around that right ureteric orifice area from previous TURBT. Antegrade DJ stenting attempted. However, distalmost ureteric dense stricture. Hence, it was not successful, sir.
Okay. So the cause of stricture was?
Yes, sir.
What was the cause? Probable cause?
BCG related, sir.
No, I'm just asking. I mean, was it related to was the tumor on the ureteric orifices or ureteric orifice, right side ureteric orifice where there is a stricture?
So probably, I think this TURBT was done outside. So I
Okay.
think they did not stent it. And maybe they used coagulation current or what, but
So more the reason whenever TURBT is done from outside, you don't know the person, then ideally, and for other cases also, you should definitely perform restage TURBT or relook TURBTs. In that, maybe that time you could have seen a narrow orifice, you could have stented it, and this could have been prevented. Okay, go ahead. Okay, so what will you do now?
So in this case,
Sending the
there was
DJ into the PCN.
Sorry?
right percutaneous approach to main evidence because right ureteric orifice was not visible and also stenting was not possible.
I'll tell you, there is a little change in the history. After BCG, he had a frequency, urgency, and his bladder capacity had decreased. Plus, he had obstruction on the right hand side. So it was a small capacity bladder with obstruction.
Okay.
And this is exactly 1 year back. About almost 1 year back.
So could be the
That is the time he came to us.
Could be the BCG reaction. Okay. Okay, go ahead. Next.
Yes, sir.
Now, how will you manage Shashank and Ellen? You have put a stent. Then? Sorry, not stent, PCN. Then?
Sir, any lesions in the bladder, sir, in the cystoscopy?
No, right now, there are no lesions in bladder. Now, it is more of non-oncological management. Oncology, you are already done. BCG has been given. Now, it is a moderate to gross hydronephrosis. You have to manage this. How will you manage?
Check his renal function first, sir.
PCN anyway, it is inserted, sir. We have to see for the output from the right PCN.
Output is okay. Output is good.
We can do a nephrostogram through the PCN only, sir.
Good. Then? Nephrostogram hai, Rahul?
Yes, sir. I'll show.
Okay. Describe this.
Nephrostogram of the right kidney showing
the moderate dilatation of pelvic calyceal system and till the level of
pelvic calyceal system. Bilateral.
Right-sided moderate dilatation till the level of the distal ureterus.
Of right side.
Right side with the PCN in situ.
Correct.
Tapped out cutoff at the distal ureteric levels.
Right. So the diagnosis is
entering the
right distal ureteric strictures.
okay. So what is your next plan of management? How will you counsel this patient?
Because the patient is also having a small capacity bladder, sir. And,
Now, my question is whether you like to give anti-cox treatment or not.
Sorry, sir.
Sorry, sir. Can you please
Any
repeat the
one
question,
of you
sir?
will like to give anti-shock treatment?
But since the patient has presented with severe LUTS and there is decreased capacity of the bladder also, and there is a distal ureteric stricture, we can try to diagnose if there is any active acid-fast bacilli in the urine, and if there is a like there is positive, then we can start on empirical anti-tubercular treatment, sir. We can give a trial, sir.
How will it help for LUTS? You are saying?
Yes, sir. Sir, if it is due to the BCG treatment, then anti-tubercular treatment might help, sir, because the bladder capacity has also reduced significantly, and
Okay. Now, what about this narrowing? How long will you keep the PCN? You have to do something for this PCN, right? What is your plan? You did whatever, I mean, urine cytology or urine BCG evaluation, it is negative. You are not starting any anti-tubercular drug.
yes, sir.
Then what is the next plan?
Yeah, Karan, what you will do? What you will do?
Small capacity bladder with distal ureteric stricture. If you are saying no ATT, should we go ahead with the augmented cystoplasty with ureteric reimplantation, sir?
How small is the bladder? I think it was 250 ml,
250
right?
ml, sir. 250 ml.
Okay, and how severe were the storage LUTS?
He was
Sir, the
getting
severe
up 3 or
LUTS.
4 times in a night,
Okay,
and about 1.5 to 2 hours, he was able to hold it.
okay, okay, got it. So,
Before definitive management, should we go ahead, like you said, check for the urine tuberculosis? We have to check it, start ATT, sir, before start doing any.
okay, you did it. It was negative. You are not planning to start AKT. So, you will directly start. You will directly go ahead with radical cystectomy for this.
Not radical cystectomy, sir.
Then you said no radical cystectomy. What did you say?
No, sir. Augmented cystoplasty with ureteric reimplant, I said.
Augmented cystoplasty. Okay,
Small capacity bladder,
but
severe LE.
won't you try some anticholinergic medicines,
Anticholinergic, yeah,
medical
definitely
management?
anticholinergics.
Okay, and what about this stricture?
So for that, we have to do reimplantation. But we cannot
Directly
keep the treatment
reimplantation.
for.
Won't you give another try for this maybe antegrade stenting, some dilatation? At least one try you should give.
Yes. So after 2 to 3 weeks, we can attempt for an antegrade stenting, and if at all, if we are able to pass a guide where we can attempt for antegrade stenting, and then after that we can do a repeat ureteroscopy to and RGP to assess if the stricture is still there or it has resolved.
Correct.
If still it is there, sir, we can go for any endoscopic management like balloon dilatation or even laser management by ureterotomy.
So let me tell you, we observed this patient for 1 year, almost for 1 year. There was a nephrostomy. In between, we have done a cystoscopy, check cystoscopy to see whether we can put a stent anti-grade, retrograde. Not possible. Number one, and there was no lesion seen in next 1 year. Now what we will do? Current augmentation with reimplantation, only reimplantation, if the nephrostomy for another 1 year, 2 years, or do radical cystectomy. Current session,
Sir, bladder capacity is around 250 ml. In this case, I would like to, and the opposite kidney is normal, sir. So, ureteric reimplantation on the right side.
Why not augmentation?
Yes. Augmentation can also be done, sir, because of.
See, boys, I think there is some error which is happening in the thinking. First and foremost, you have called this as a lower ureteric stricture or distal ureteric stricture. It will be at best called as a stricture in the intramural ureter. Okay, you can call it lower ureter, that is okay. Now, if you want to look for tuberculosis, you will need to do a bladder biopsy. You cannot diagnose tuberculosis by urine BCG evaluation. Urine for AB culture, because possibly post receiving BCG, you can get a false positive culture report. There is no question of doing a antegrade stenting, because before that you will do a antegrade nephrostogram. If no contrast is going down, then how can you do antegrade stenting? And again, before planning a augmentation cystoplasty, you need to do a bladder biopsy to confirm no COX, no tumor. So this patient will need random bladder biopsies before you take any call. In all probability, a proper biopsy may show some tuberculosis. Patient may benefit by AKT in this situation. So I would feel at this time cystoscopy, bladder biopsy, SOS AKT, continue on nephrostomy tube, do intermittent nephrostogram, see whether contrast is going down the bladder. Only when it goes down, then consider stenting. Otherwise, later on, you can think about augmentation with a reimplant. Was I audible?
Yes, yes.
Yes, sir.
Perfect, sir. Agreed, 100% agreed. And in non-muscle invasive, though it is non-muscle invasive, I would usually not prefer to go ahead with augmentation cystoplasty unless it is a low risk category. It is okay, but in high risk for oncological factors, usually augmentation cystoplasty is deferred as far as possible.
Or at least they should be cancer free for 2 to 5 years or whatever.
Somebody asked about TUU. Never do TUU, especially in the lower ureter, because for lower ureter, reimplant is a much simpler option, and TUU carries a risk of tempering the opposite normal side. So this patient, and with the stricture so low near the bladder, doing a reimplant in this patient will be very easy. You would not even need a Swas hitch for this reimplantation. Again, in an adult, we are not looking at a non-reflexing reimplant. So even a Lisch-Greger reimplant, as we do in transplant, would be more than enough for this patient.
Contrast is going quite all the way till down, sir. So
yes, it is nearly that in the bladder.
So
I would say the stricture is more in the intramural ureter than in the lower.
Absolutely, absolutely. Maybe is that just the resection that they would have burnt it probably.
Absolutely.
I think then looking at all your inference, we did the right thing. We have done the reimplantation of ureter.
Absolutely, sir. Means this patient would need a reimplant at some time, but before that we need to rule out regrowth and we need to rule out no tuberculosis.
So we waited for 1 year.
Right.
And all the reports, cytology, everything was negative for 1 year. So now we have done reimplantation.
Perfect, sir.
Saurabh, will you like to throw any light or any from you?
Nothing, sir. It was a good discussion.
Your presentation was also excellent.
Thank you,
I
sir.
really liked it.
If anybody has any student has any questions, we can discuss maybe next 1 or 2, 5 or 10 minutes, or we can conclude then.
I think we can conclude now. Next time we'll have muscle invasive.
Sure.
Perfect. Chalo, thank you, Saurabh.
Thank you,
Thank you.
Saurabh. Thank you, Pankaj sir. Thank you, Gaurang
Pankaj
sir.
bhai, thank you very much. Gite sir आज कुछ
Gite
बोले
sir,
नहीं.
Gite
थैंक
sir
यू
भी
सर.
आए हैं.
सर सौरभ हैज डन एक्सीलेंट जॉब. मुझे बोलने का कोई चांस ही नहीं था.
I heard him in Aura and I was so impressed. So I told him, I want you to teach our students. Excellent. Thank you very much, sir.
Thank you, sir.
Thank you for joining, Saurabh.
Thank you.
Thank you, Gite sir. Thank you,
Thank you.
Pankaj sir. Good night.
Good night.
everybody.
Good night.
Thank you, sir.
Rahul, you will have to end the meeting for everyone. No? If you
Yes, sir.
are
I'll end, sir.
You just end the meeting. Huh?
Yes,
Thank you.
don't leave it. Okay?
I don't know
Otherwise,
who is
next-
this person disturbing the entire class. Our meeting is getting
Yes, sir. I'll
recorded.
end the meeting, sir.
No, but we have to find out who is this person who's disturbing the class.